Hello, everybody. My name is Brock Rondeau, and I've been a dentist for more years than I care to talk about. And 10 years ago, I had the pleasure of meeting DiRezze at several of my courses. And he was a good student. He took all the ortho courses, which involve functional appliances and fixed ortho. And he took the TMD courses and the sleep apnea courses and snoring. And really, I think, really rounded out his education. So he's able to look after the total health of the patient, not just his teeth. And now it's reversed. He's now teaching me. So that's good. He's teaching me about Invisalign and clear aligners. And I passed it on to my new partner, Sep, and let him really go with it. And they're developing our course together, developing our office together. Ron has a fantastic course. It's a 2-session, 4-day course, which is very comprehensive. We also encourage your staff to come because it's very important. Ron will talk, I'm sure, a little bit tonight about the importance of his team and how they all have to know what's going on, which helps educate the patient. So I've also got Bill Van Evans here, and Bill Van Evans has been working with me for the last 30 years with functional appliances. And Ron and Bill and I all agree that if the patient comes with a really, really constricted arch and they're having trouble breathing through their nose, and they may have some jaw problems, which we cover in the course, they need to be expanded. And you can maybe expand maybe 2 millimeters with Invisalign trays. But if the arch is really constricted, you need a functional appliance to expand it, and you need either a removable or a fixed appliance to do it. Also, we all agree that the best Invisalign cases are the class 1s, skeletal, with no big overjet. And we like to treat the class 2s and the class 3s before we put the Invisalign trays on. And that's where Bill comes in, because he's got all kinds of appliances fixed and removable to do that. The other thing I'd like to tell you is that for patients with deep overbites and temporomandibular joint dysfunction, the ideal treatment is to use your Invisalign trays and extrude the posterior teeth. Now, that's new for most Invisalign providers because most times with Invisalign, you intrude the incisors. But I can tell you that's not the ideal treatment for patients with temporomandibular joint problem. And in our course, we cover quite a bit on TMD so that you won't make that mistake. The other one quick thing I want to tell you is that if the patient's clicking, I advise you not to use your standard upper night guard or your Invisalign trays. I've had at least 10 patients have their jaw lock on Invisalign trays. And of course, I do TMD in my practice, they send them to me. So I really think if you take his course, you're going to learn how to move teeth, but you're going to learn how to make the patient healthier too. Now, the last thing I want to say about Ron is that he lectured to 450 hygienists about a month ago. And we sent out evaluation sheets, and it came back, he was the sexiest man in Detroit, sexiest dentist in Detroit, okay? But they also added some other things. Ron said, but you didn't mention all of it. I said, sorry, Ron, but I didn't want to build you up too much. He said, well, you should tell them everything they said about me. I said, well, they also said he was the most handsome dentist in all of Detroit. So now, Ron, I've told them everything they said about you. So, let me just introduce Bill for a minute. Bill, you've been working with me for 30 years. We've helped thousands of patients. You're knowledgeable in TMJ, sleep, and ortho. And just introduce yourself and tell them that you're the guy they want to send those appliances to. So in our course, we'll be recommending they use you.
Thanks, Brock. It's it's a pleasure to have worked with you for all this time. We've done some great things for a lot of great patients, and we've seen what we do change over the years. And I think we're in a great spot now to certainly help people with ortho, TMD, and sleep. And I know your practice has grown immensely by focusing on those areas. So it's great that we've been able to help all these people all these years. And I think we're in a good spot to help any other dentists that are listening in tonight. So I know you're going to learn a lot from Ron, and as Brock says, he's got a great course on working with aligners to give patients what they want these days. And it's clear trays, straight teeth, healthy smile, happy smiles and healthy joints. So thanks for being here.
Thanks, Bill. Ron, it's all yours, my boy.
I'm going to go. Thanks, Brock. Thanks, Bill. Nice to see both of you guys. Let me go ahead and share my screen and start with my PowerPoint. Looking for PowerPoint. Hold on.
Well, while you think of that, I would say that the reason I wanted Ron to lecture on the Clinchecks tonight is that we have a tendency to rely on the non-dentists in Costa Rica to make our diagnosis sometimes. And many course participants bring their cases to Ron that have been, the Clincheck's been done by Costa Rica.
Yeah.
And Ron will take the case and just say, okay, that attachment's wrong. You need to put this attachment here and that attachment there because this will happen, this will happen, this will happen. And we found it extremely interesting. And that's why I'm really happy that he's here tonight to share some ideas on Clincheck. Obviously, his course is like 4 days, 48 hours or something, or no, I guess 8 days an hour, 48 hours. So we can't cover all that tonight, but he's going to give you sort of an overview of the Clincheck.
Yeah.
And hopefully you'll want to take his course and improve your techniques.
Perfect intro. I think I got my screen shared. And there we go. Can you see that?
Yeah.
Yeah.
This is my motivational slide that I show to all the students at Brock's course. And it says it's time to start something new and trust the magic of new beginnings. I certainly did that. And it's paid off professionally, personally, in my practice, in my life for me. I am Arnaldo. My name is Ron DiRezze. Here is my email, ron@shelbydental.com. This is my cell phone should you need to text me or get a hold of me with any questions or concerns about anything that I've said this evening. By the numbers, 23 years as a dentist, 21 years as a practice owner. Thousands of patients have come through my doors, hundreds of smiles. I teach a 4-day comprehensive clear aligner course, as Brock said. I'm a 5-time Invisalign Platinum provider. I hold 3 fellowships and I hold a board of directors seat in the American Academy of Clear Aligners. I am really looking forward to this Zoom meeting tonight because Brock's got me flying all over the country teaching clear aligners for him. And I literally take my life in my hands every time I get on an airplane because I'm a white knuckled flyer. This is me flying into Chicago at about 5 o'clock in the morning last year or the year before. And I know it's a light dusting of snow, but to me, that looks like a blizzard. And plane was landing. I look out, I see the snow and I'm thinking, we're just going to keep sliding here. I wondered if I would ever make it to the Marriott and teach Brock's course that day. So Brock Rondeau, a little bit about him, as we all know, international leader for decades at continuing education, ortho, TMD, sleep, educated thousands of doctors, myself included, with complete continuums over the last 30 years. Still wet-fingered, although he told me that he only works a couple weeks out of the month now, travels the other couple weeks. Uses all of the materials and methods that are in his course and that I teach in my course. And he's extremely vested in your success. He wants you to be successful via comprehensive didactic training and hands-on training. He believes that you should diagnose and treatment plan and deliver care to the best of your abilities to better the lives of your patients. Here are the fellowships that I hang on to. Pierre Fauchard, ICOI, Board of Directors seat on the American Academy of Clear Aligners, and this is the fellowship badge that I received. So why am I here and how did I get here? What qualifies me to be here? Well, here's me receiving my fellowship in Vegas a couple of years ago. This is Dr. Galler on the left of me and Dr. Phil Godden from Vancouver to the right of me. And interestingly, when my mom asked me about the ceremony, my mom's on the call tonight. My mom asked me about the ceremony and she said, well, what did they do for the fellowship? I said, well, you walk across the stage and they have this announcer that says a few sentences about you, like where you live, what you do, and how you practice and where you work. And she says to me, the first thing she says, she pauses and says, well, I hope you told them that you're Canadian. And I said, well, of course, I tell everybody that I'm Canadian, that it's the most important part about me, where I came from. And I think that's one of the things that qualifies me to lecture for Brock, because he's from London. In my course, we talk a lot about change. Change is hard, but change is necessary. Changing your practice is good. Change requires taking you out of your comfort zone, requires breaking down barriers. And every 10 to 15 years, something new comes along and changes the way we used to do things. Here's my 23-year-old assistant, Rachel. Hey, Doc, what's this? Pointing to the light that's above the door, not the reflection of the exit sign. And I just started laughing because, of course, most of us know what that is. That's the red light that says that you're processing x-rays in your dark room. And we all know that when the red light's on, you don't walk into the door, because you're going to expose that x-ray and it's not going to turn out. Okay. Doctors on the call, if you were to go to a job interview next week, if you were leaving your practice or going to get an associateship someplace, and you walk in and the doc says, now listen, I pride myself on the quality of x-rays. We fill up these dip tanks every 3 days. And you saw this, what would you think? Okay. My first job interview in the year 2000, when I graduated, the ladies at the front desk said, Doc, we're so excited to show you our new charting system. Charting system? What'd you guys get? Dentrix? Did you get EagleSoft? No, we got these things. I was like, what? That's your new charting system? What was the old charting system? Because this to me is the old charting system. You know, if you rummage through your lab and you found these anterior bridges with metal collars, what would you think? If this was the quality of care that we can deliver with our anterior aesthetics, what would you think of working here? Or what would you think of being a dentist in this day and age? Okay. An older generation dentist, you should be able to tell them, listen, one day we're not going to have any metal underneath our bridges. And what's more, one day we're not going to have any bridges. We're going to put teeth on these screws that go into the bone. Okay. All of these offices had to change. Okay. And every one of them was busy. Their workflows were good. Nobody wanted to rock the boat because everybody was making good money. But in 2023, all of these things are obsolete, and nobody here would work in any of these offices that I described. And the doctor would have a hard time finding team members. Here's what change has done for me. These are my Invisalign numbers. Okay. And I stopped at 2021. This is 2 years after the fact now. And I assure you that graph just keeps going onward and upward. Okay. Here's my tier jump ring from the AACA, and here's my fellowship ring from the AACA. Okay. I'm a 5-time Invisalign Platinum provider. I'm a single practitioner. I work out of a single office. I don't cheat. Nobody that knows me is going to send me any cases to do on their behalf. And I've done this basically up until recently. I've had no social media game. Here was my Instagram for years and years and years. It has 2 pictures, one of my dog, one of my kids putting gummy worms on my face. And that was it. Okay. Tonight, we're going to talk about how to set up a Clincheck for success. But there are so many aspects to success. We could have a separate webinar on case presentation for success, case selection for success, delivery of care for success, patient management for success, compliance for success. Okay. I go through all these things in details Brock mentioned in our 4-day course. Here are the upcoming dates: Toronto, Dallas this year, and Chicago. Please speak with Lee if you have any interest, or if you want to ask about the curriculum, go ahead and reach out to me. I have no problems answering questions. Okay. Here's our roadmap for tonight. How to Clincheck for success. We're going to talk a little bit about treatment goals and what is success, case selection criteria, Clincheck considerations when I look at a Clincheck, movements that you can and cannot live without. Okay. Treatment goals for success. In 2019, when I got into this game, we used to say 20 trays in, 20 trays out. We're getting slowly and slowly more spoiled, because today, that average with GLR, that means artificial intelligence protocols, we're averaging 17.5 trays of treatment time. And that's a game changer. Okay. You have to be on certain algorithms. We could talk a little bit more about that outside of the scope of this webinar, but there's certain things, certain courses you can take in order to get on GLR protocols. Another treatment goal: solve the patient's chief complaint. Interestingly, that could be different than the diagnosis. Your patient would not come in and say, I'm a class 2 Div 2. Your patient would come in and say, I got these crooked teeth, I need fixed. Okay. Treatments for those two things are very, very different. The treatment from an orthodontist would be different than treatment from a general dentist with those two things. Okay. We want to achieve minimal mid-course corrections and minimal refinement rates and no posterior open bite. Okay. The main point of quote unquote success is that your time with your patient is limited before your patient asks you, gosh, doc, do you really know what you're doing? And younger practitioners on the call, buckle up, because if you haven't heard that yet, one day you probably will. And it's extremely humbling. Okay. So with Invisalign, you want to be decisive and quick to act and make sure you elicit a response or a change for your patient. Okay. Every discipline in dentistry works the same way. It goes like this. You put in maximum effort on the way in for an easy payoff at the end. When we do a crown prep, we spend an hour making the angles proper, making the tooth smooth, reducing properly. And then the time we take dealing with the sulcus, packing cord, laser, whatever it is that we do, scan, take an impression, all that work for a 5-minute crown seat. Implant placement. Most of us are doing surgical guides. I do surgical guides so that I don't have to schedule 2.5 or 3 hours for a single implant like I used to do. I do surgical guides now and I schedule it like a filling. I sandwich it in between fillings. And I don't think twice. It's my number one efficiency hack is surgical guides and scheduling them for an hour in between other procedures. Bracket placement. Brock taught me how to put on brackets. I would spend an hour or more with the little pitchfork thing only so that I can change wires in 10 minutes every time the patient would come back. And that would bring me to the completion of the course. Invisalign and clear aligners is no different. You get out what you put in. If you put minimal effort out, it's going to be a long, hard road to bail yourself out. But if you're diligent and studious and didactic at the onset, your case will go according to plan. Treatment objectives for me are always the same. Better perio health, better function, better overall health, better life. And way down on the list is aesthetics or cosmetics, because that's just the nature of the game. Better aesthetics will come. But for me, it's perio health and function and overall health and life. Okay. Mission statement from the AACA. A healthy smile enables a person to reach their maximum potential in life. Coined by Dr. David Galler, that taught me. Okay. And something that we try to live by every day. Case selection criteria. Okay. You want to jot this down or take a picture. No growing class 2s, no growing class 3s, no posterior bilateral crossbite, no reverse overjet, and less than 50% bone loss, usually in the lower anterior. That's the limiting factor right there. Of course, there's exceptions to every rule. If you want to do a class 2 or a class 3 case, Invisalign has perfect appliances for you, mandibular advancement or mandibular first, or you can apply a functional appliance, but that requires a knowledge of cephalometrics. You need to know how your patient is growing in the vertical dimension, because you just cannot apply elastics to any case. You can't apply functionals to any case unless you have a proper diagnosis. Brock did a great job teaching me early on. And it's something that when I attach mechanics or functional appliance, I get a ceph tracing each time, and I just have it with me so I can refer to it. Okay. Here's an exception to the rule. This is a reverse overjet case that I did. Okay. And here's where he stands right now. That's a pretty life-changing thing for my patient to go from what you see on the left to the right. Okay. Here's a case here. Here's an exception to the perio rule. This gentleman had more than 50% bone loss, but I had a long talk with him. We had a wonderful informed consent, and he felt like he wanted it. I felt like he needed it, because how is he going to keep clean the upper lateral incisor? 2-2, or what we call 10 over here. Okay. Here's his x-ray. It's not great. It violates the rule, but here he is at the end, and he's able to keep things cleaner. And he's ready to be shipped off to periodontist to see what they want to do about it. And I think you see the look on his face. He's happy he did it, you know. Here's a case here where I felt like my patient had no alternative. We had to jump in and do treatment, because without treatment, everybody look at the lower left canine, how it's blocked out. Without treatment, those teeth are doomed. Okay. Probably with treatment, they're going to be doomed, but I'm hoping to get her at least a little bit extra time. And I'm hoping to get her straighter teeth and a better smile. Okay. Here's her pre-op x-rays. Here's at the end of treatment, ready to be shipped off to the periodontist for grafting or whatever they want to do in the lower anterior. Okay. Here's her x-rays there. Not great, but better than what she started. Okay. But for me, the payoff is this here. When I have a patient that starts like this and ends up like this, that makes all the difference to me, and that makes it worth it to me. As long as they're informed, as long as they sign the consent, they know what the pitfalls and the risks of treatment are, they're usually pretty amenable. And I think, again, the look on her face tells me that she's happy that we did what we did. Okay. So the take-home message here, I believe, is that success is what you want it to be. Doesn't have to be burn through the tears at Invisalign. Okay. It could be doing 5 cases a year with functional appliances. It could be using mandibular advancement. It could be treating teens. Whatever gives you professional gratification is what success is. Okay. We're here to teach you tips and techniques to help you achieve what you want to achieve. If you want a streamlined and rubber stamp treatment, stick to the selection criteria. Fill your office with easy adult class 1 treatments or class 2 treatments and not moving molars and prescribing heavily to IPR. You could do that. Okay. And stay in your lane. But it can be rewarding to go outside of the lines with proper education and make a difference for your patients. My Clincheck considerations, an overview of treatment. Are the attachments correct for the desired movement? That requires knowledge of attachments. Do I have adequate anchorage, which I'm going to teach you about tonight? What type of case is this, and what is the diagnosis? Okay. And what movements are required to solve the chief complaint and get me to the finish line the quickest? Okay. This is David Galler said, education plus confidence plus a little value will get you cases. Okay. This is the education part of the course. Adequate attachments. Okay. Let the attachments tell the story of where the teeth are going to move. Okay. Again, that requires a didactic knowledge of attachments. Okay. To do this, you have to master the attachments. You have to study them. You have to know when they're prescribed, why they're prescribed, and what they do, how they work. My first course in dental school was dental anatomy, and attachments is kind of like Invisalign anatomy. Okay. In our 4-day course, we spend, I would say, at least, if I tried to count it up, because we do it on day 1 in the morning, and then we review on day 2. And then most of the students want to review on day 3. So we spent hours on attachments, and we do quizzes. I kind of have like a drill sergeant where I just, point it out, and the class has to shout back what the attachment is. And at the end, they are really, really good at it. Okay. My mission is to make Brock's doctors better than everybody they know at attachments. And I stopped short of writing down better than an orthodontist, because I don't want to get into that game about, general dentist versus orthodontist after the first dagger the AAO threw at us. However, my goal is just to get proper education before you jump into Invisalign. So that way, nobody can say anything about you. No one can say anything about your treatment, and no one can talk down to you. Okay. And that only happens with education. Okay. So what are the attachments and what do they do? And we're just going to do a brief overview here, but I'm going to tell you that each one of these attachments has a shape, and kind of like form follows function. The shape, it has a reason for the shape to do what it needs to do. So the first 4 attachments on, I did not think of highlighting my mouse, but I'm hoping you can see my arrow. So attachments 1, 2, 3, and 4 are horizontal rectangles. Horizontal rectangles in our Invisalign protocols do nothing. They are for anchorage. They hold the trays in place. Okay. So this is a visual here. This is a pattern that you need to recognize on every single Clincheck. This is anchorage, and we're going to go much deeper into anchorage, okay? This happy face is a deep bite attachment. This is going to help. When you see this, this means that there's a deep bite someplace that they're going to solve. The deep bite is the two front teeth, okay? This is a root control attachment. This means that the tray is going to put pressure on the flat. It's going to scooch this root just a little bit, just a little bit. It's just going to elicit a response just a little bit here by pressing on the flat. This attachment here, this is not a rectangle. This is called a skateboard. They call it the skateboard ramp, okay, because it looks like a skateboard. This is a pure extrusion attachment. The tray sits here and puts force downwards, and it causes this tooth to extrude, okay? Coming down on the bottom here, horizontal beveled attachment for anchorage, horizontal beveled attachment for anchorage. Upside down smiley face, this is the same as this, just upside down on the opposite arch. Optimized deep bite attachment. This is going to help solve the deep bite that exists on the lower anterior teeth, okay? This attachment here is called a raindrop. I think it looks like a windmill, and it helps me figure out what it does, because the fact that it looks like a windmill means that it's going to spin this too. So this is a rotation attachment. This does nothing except spin the crown and the root of this canine into position, okay? Coming up on the other side here, horizontal beveled rectangle for anchorage, horizontal beveled rectangle for anchorage, horizontal beveled rectangle for anchorage on the bottom, and again, horizontal beveled rectangle for anchorage on the bottom, okay? On the first premolars, we see optimized deep bite attachments. The smiley face and the upside down smiley face means that you were going to solve the deep bite. So when you see this, this means, I got a deep bite, okay? When you see raindrop here, it means we're going to rotate this tooth. When you see optimized root control attachment here, it means that the tray is going to press on the flat and just scooch the root just a little bit. And the skateboard ramp here is an extrusion attachment. We're going to pull that tooth down where it needs to go. Okay, let's take a look and see here how this works. So this is the same plan. So we see we're going to solve the deep bite. So 8 and 9, 1, 1, 2, 1 are intruding. The lateral incisors are extruding. The canine is rotating into position. Okay, so the proper attachments were placed for the movements that were prescribed. Okay, let's take a look at the bottom teeth here. We're going to see solving. This is obviously a deep bite that needs to be solved here. So we're going to take a look at this here. This is going to be solved by using the deep bite attachment here and the deep bite attachment here. Lee, would you text me and just tell me if you can see my mouse pointer? Again, let's take a look at these attachments here. Horizontal bevel for anchorage, horizontal bevel for anchorage, horizontal bevel for anchorage. Optimized deep bite attachment. We're going to solve a deep bite on the lower, and this attachment is going to help us. This is a smiley face. This is a retention attachment. This is going to aid in solving this deep bite. Okay, so these central incisors are going to intrude. Come back here. These central incisors are going to intrude, and the tray is going to rest here, and it's going to give a fulcrum. It's going to help us. Okay. 1, 2, 3 horizontal bevels for anchorage. The trays lock into here and don't give it any play at all. Okay. Upside down smiley face means that we're solving a deep bite in the anterior. We're going to use this to help us. Okay. This is a root torque attachment. So the tray is going to give pressure on the flat of that attachment and scooch it just a little bit. This is a support attachment to support in the deep bite here again, just like these ones do. And this is a root torque attachment. The tray is going to give force just on the flat. That's going to scooch the root over just a little bit. Okay. Not a translation, a root tip. Okay. Purpose of attachments. One of them is anchorage. The teeth that are not moving need to provide resistance to the teeth that are going to move. Okay. Teeth we want to move need to overcome their anchorage. They are anchored in PDL, bone, musculature, and their malrotation or malposition sometimes. We don't want to slip any anchorage because that's going to compromise our movements. Okay. In a nutshell, this is why Invisalign doesn't work. If you talk to Most dentists that have tried Invisalign that have switched to a different company, they say Invisalign doesn't work. This is the reason why. This is it in a nutshell. This is anchorage, or this is lack of anchorage. Okay, that's easy enough to understand, but this has happened to all of our cases, or most of our cases that are people that are on this call. I'm almost certain. Okay. Horizontal rectangled beveled attachment for anchorage. That's these two right here. Bevel towards the occlusal, because when you slide the tray on, you want the tray to click over these right angles right here. So patient's going to insert the tray from the occlusal, they're going to seat it gingivally, and the trays are going to lock in underneath here, okay? That is going to give anchorage or resistance to Newton's third law, and it's going to allow anything that needs to happen in the anterior, it's going to facilitate that without the tray slipping off, okay? Can everybody understand that? Okay, trays click in over large attachments, okay? I happen to have this set in my parameters. You find this sheet in any clear aligner software that you happen to be using. These are parameters that you can set. And mine happen to say on every premolar, put horizontal beveled rectangles that are beveled towards the occlusal, because I want them to slide on easy, but then lock in underneath. Okay. So find this representation and set this in your parameters. Okay. Elements of anchorage, horizontal bevels on all premolars, unless it's superseded by another attachment. Okay. Attachments on maxillary lateral incisors and a full distal wrap. Distal wrapping your terminal molar provides anchorage as well. This case happens to have good anchorage. Okay. And I pointed out why. Full distal wrap. The tray is able to grab all the way behind the tooth, right down to that neck of the tooth at the gum line. Okay. Horizontal bevel, and attachment on the lateral incisor. These three things here give this tray stability so that when there is movement programmed on another tooth, it is able to elicit that change without slipping anchorage, without dissipating the forces applied to that tooth. Okay. This happens to be poor anchorage. There's a very long span here without any anchors, and there's no full distal wrap. So we need to add anchorage. Okay. And here's how we add anchorage. I have a series of screenshots here. So I've opened up my modification. This is my tooth tab. So I make changes to individual teeth, but I want my features tab. So I'm going to click my features tab, and here's all the attachments that are available to me. Okay, I'm going to hover over the rectangle horizontal incisal attachment. That means that it's rectangular, it's horizontal, and the bevel is towards the incisal. That's the one that we want. It's always right here. It's always on the left-hand side. Between the two, it's always the left one, okay? And my mouse didn't show up, but this is me dragging it into place, and we're going to drop it on that molar. Okay, we're going to drop it on the molar because we need more anchorage because we don't have a full distal wrap. So I've just increased the amount of anchorage that I have, okay, in order to elicit the change that I need to elicit. Okay. I think we're going to play this now and show you how it goes in real time. New modification. As I said, this is the tooth chart that shows up. We want to click on our features so the attachments show up. Drag horizontal bevel attachment onto the molar. Drag and drop. The software will optimize where it goes, how it's positioned, and it's good to go. Okay. Does this case have good anchorage? Okay. No, because just from a pattern, you do not have to figure out what's going on. But from a pattern standpoint, we don't see any rectangular attachments. We don't see any rectangles here. So this case, just by definition, does not have good anchorage, okay? Because these trays, even though there's a flat, these flats are beveled, and the trays cannot click in, the trays cannot lock in, and the trays will slide over curved or smooth surfaces. So we need to have rectangled, beveled, horizontal attachments so that the trays can click in, okay? In terms of attachments, here's one that we haven't seen before. This is called the double spike. This is a translation attachment. So you can imagine that the tray will put pressure on the flat of the attachment here, and the tray will put pressure on the flat of the attachment here. and it'll scooch, shimmy and shake all the way over to where it needs to go. It'll just go sideways. Okay. And it happens fairly predictably in the anterior, not so in the posterior. So we try to limit this to an anterior attachment only. Okay. Is this good anchorage? And what are these attachments? Okay. This is an optimized deep bite attachment. This gives you a clue as to what's going on in the anterior. By putting this attachment here, by recognizing the pattern, you think, okay, this is an optimized deep bite attachment. We're solving a deep bite here in the anterior. Okay. This is a double spike attachment used to translate teeth. So this tooth is going to be going sideways someplace. This canine is obviously going to be going sideways someplace. So they put a double spike attachment here. This is a root torque. Oops, sorry. This is a root torque attachment. It's not really in favor. And I explained in the course in detail why it's not in favor, but we prefer an attachment more centrally located on the lateral incisor. This one is too far away from the center of resistance, which is in the middle of the root, to elicit a change. It's really not a great attachment to use. And here's a double spike for a translation. Okay. Does this case have good anchorage? Absolutely not. There's no distal wrap. There's no two premolar elements that are a horizontal rectangle, and there's nothing in the anterior. Okay. This is a deep bite. They're going to solve this deep bite here by leaning against this attachment. And this is an optimized root control that they're just going to put pressure on it. It's going to move just a little bit. Okay. This is not good anchorage, but this is a double spike attachment where they're going to attempt to move a premolar sideways. It's not really a preferred movement. This is a raindrop. So they're going to windmill this tooth into position here. They're going to rotate it. And this is a vertical bevel, a vertical rectangular attachment that they're going to use to swing this tooth someplace. There is no good attachment here. There is one element of anchorage right here, but it needs more. Okay. I always look at a Clincheck and I say, do the movements make sense for this particular case? And we'll talk a little bit about class 2s, class 3s, spacing cases, crowding cases, deep bite cases. First and foremost, class 2 cases. If you're looking at a class 2 case, you need IPR almost 100% of the time. There's not usually a class 2 relationship that you can find that does not require IPR on the top to establish adequate overjet and overbite. Okay. So here I am with my setup. I've got IPR across the top. Now for the inexperienced users, this is IPR is smoothing or slicing or gently flossing in between the teeth. Brock puts a nice article in his level 1 course about how safe IPR is. Is 0.2 millimeters, 0.3, 0.2, 0.2, 0.3, 0.3, 0.2. That will cause all the teeth to go backwards and establish good overjet and overbite without touching the molars. Okay. There's overjet before and after. Okay. We see the difference there. Mandibular crowding and tight overjet cases obviously are dependent on IPR. Okay. Now this is about the maximum amount of IPR that I ever do, 0.5 between distal of the canine to distal of the other canine. Okay. IPR is needed for proper overjet, and crowding can be solved by expansion only, but there would not be enough overjet. Okay. And the other thing I noticed is that there's also spacing on the top. So when the space is consolidated on the top, you need that much more IPR on the bottom to reestablish proper overjet. Okay. End-to-end anterior open bite, heavily dependent on IPR on the bottom. And what's worse is this case, most of these cases have spacing. Okay. So you might have to go into another round of IPR, or you might need to extend that IPR back to the molars. Okay. Very safe, but difficult to solve this because you have to be good at IPR, and we'll talk about that in a little bit. Okay. Here are those skateboard ramp extrusion attachments that I talked about earlier. The trays click on, so they click on your anchorage on the premolar area, and they go over this, and they will put pressure on this 45-degree angle and cause extrusion of the anterior teeth. Come back here. Okay, cause extrusion of anterior teeth. Okay, very predictable, sometimes time consuming. It all depends on anchorage and patient compliance. Here's a case that I dove into. Okay, and this gentleman, I talk about him in my courses, but he needed this. He needed this in his life, and I brought it to him, and I made him see the light. And I did this because he needed to have this. Okay, here's his setup, up close, all extrusion attachments all the way across the top and the bottom, just about. Okay, and here's where I got him. Okay, it's life-changing for him. Okay, life-changing. Okay, it's not perfect like straight wire. I don't think we can ever achieve that in this case with straight wire. He's got a bilateral posterior crossbite, so that's complicating things. But he had the option to go to an orthodontist. He didn't want to do that. He wanted this resolution here. Okay. Maxillary and mandibular crowding. Okay. We solved this with expansion in the premolar area. Okay. Take a look here. This is expanding. And this was expanding. Okay. Going to play this again. Class 1 case, expansion only case. Okay. Again, spacing case. I alluded to it previously. If you have spaces that you need to consolidate on the upper, you need to have IPR on the lower in order to establish proper overjet. Any other way doesn't cut it, doesn't do the job. Okay. Anterior and end-to-end bite, obviously, just by taking a look, requires heavy leaning on your IPR. Okay. Upper spacing for the third time now requires heavy IPR on the bottom to reestablish this. Okay. I think we go into this case a little bit. Adding up the numbers, there is 6 millimeters of spacing on the top, but there's only 4 millimeters of spacing on the bottom. So if we want to keep the overjet the same, we need to add another 2 millimeters if we want to keep everything the same. Okay. So just by adding this up, I'll tell you, we didn't match the upper and lower, but what we did was we gained more space by intrusion. We used an intrusion protocol, and we gained space like that. Okay. Let's talk a little bit about the moves that we use. Okay. First of all, how to make space. We have expansion and proclination, IPR, distalization, and extraction. Okay. And to do this, we use our T movements: tip, translate, and torque. Tip is extremely easy. Translate is easy-ish in the anterior, and torque is not easy at all. So we try to avoid root torque movements if we can. Okay. Here's a case. Crowding in the upper anterior region. Okay. Here's her treatment plan. Severe rotation of the lateral incisors, but you'll notice no IPR, no anything, just expansion and rotation. 46 degrees rotation of 1, 2, or 7. 23 degrees of the other lateral incisor. 24 trays, no IPR. Expansion and proclination only to solve this case. Here's her before. Here's her after. I did this really early on. Here's her before. Here's her after. Before and after. Better interdigitation. I always say happy and happier. Okay. Here's a case here. Lower mandibular crowding. Straightened out. Treatment plan, 17 weeks. utilizing both expansion in the premolar area and a minimum amount of IPR. Let's take a look. Expansion, proclination, and IPR to solve that. Only 17 weeks. Only 17 weeks. Okay. Here we have some positive outcomes that I like to show. Lower anterior crowding. Okay. Solved. Okay. Expansion and intrusion only. 21 weeks. We expanded, we made room. The tray moved the lower incisors. 21 weeks, we were done. Okay. Maxillary expansion only. Same 21 weeks. Compliant patient, no refinements. Easy. Benefits to the patient were we fixed her occlusion, we fixed her function. She has better perio, better oral health. Last on the list, cosmetic. Okay. Let's take a look at this case before, my perio patient before and after. Certainly one of these teeth is easier to clean than the other one. Okay. I think any doctor here, any hygienist in the room would admit the case on the right is a dream to clean. Okay. Expansion and a minor amount of IPR, 12 weeks, 12 weeks to resolution. Okay. Lower, a little bit more IPR, a little bit more IPR to match, but extremely predictable. Okay. And I always show this case on day one at my course because I always ask the question to the doctors in the room. What do you think was the best part about this case? Do you think it was the perio improvement? Do you think it was the functional improvement? Do you think it was because we made beautiful, adequate space for a future implant? Do you think it was the cuspid protected occlusion? Nope, nothing. It's going from this to this. And I talk about this a lot in my class about the change that we can elicit in people. You can't measure this. And the thing is this here. See, she knew she was going to come in for pictures and records on day one. And this is the smile she chose to wear on day one. But she didn't know that we were done treatment when we took the final picture. And that's a common theme amongst all my patients. They don't know if they're done yet. We consult about it at that time when they're in the office. And that's when we take our final pictures. So this young lady here didn't know that we were going to be done treatment. Yet look at the difference in her eyes. Look at the difference in her smile. Before she was not warm and inviting, but after she definitely was. Okay. A treatment that she definitely needed and definitely living her best life now. Okay. Here's a case I just showed you here. Most importantly, before, after. Okay. I am addicted to the change in people. It's why I keep doing what I do. A new wardrobe, a new hairstyle, new relationships. I've heard it all. A new outlook on life and new improved self-worth. Okay. And sometimes people are looking for you to change them. Sometimes you are that catalyst. Okay. The change in teeth, I always say, is dramatic, but the change in the person is even more dramatic. Okay. If we look at this case here, simple intrusion case, simple intrusion case. Okay. 12 weeks in the intrusion protocol. Predictable and easy, no refinements. Okay. This is him before, this is him after. But take a look at this here, before and after. You can't measure that. You can't measure that in the Clincheck. You can't measure that until you take the after pictures. And even if you do take after pictures, who compares the after pictures to the before pictures? Nobody. I do because I lecture for Brock and I have to get these webinars ready. I have to get my class ready. So I know because I go through all of my pictures all the time. So this is a common theme amongst people. And this is why I can't stop doing what I do. These pictures tell a story. Here's a case here, this young lady here. Okay. Here is the setup. Now we're going to extrude the lower incisor a little bit up to the occlusal plane. We're going to extrude this upper lateral a little bit and close this openness here. Rotate the canine a little bit, rotate the canine a little bit. Okay. We have all our mechanics in place. Okay. I made a modification to a couple of attachments that I didn't like. Okay. And here's the Clincheck that I approved. Here's the movement here. Focus is heavily on expansion, as you can tell. We're going to extrude these teeth here and everything's good. Okay. Except that we went into refinement, and you can tell this is refinement because I kept the attachments on. That's why the scan looks like this. I forgot to add IPR. I did not add IPR in the first round of this case. And look at, I have a spacing case and I have a class 3 almost end-to-end case. So I forgot a basic rule. Class 3 always gets lower IPR. And she also had spacing on the top requiring IPR. So you cannot neglect the IPR. You can't change the rules of dentistry usually. So the first year I spent maybe trying to limit the amount of IPR that I do on people, but I realized that it gets me into trouble. You need to have IPR to establish adequate overjet and adequate overbite. Without it, you're compromising your care because it can lead to posterior open bite. And if your movements don't go to completion, you'll end up in a refinement. So adequate overjet, adequate overbite, adequate IPR is mandatory. It's what I teach in Brock's course. Okay. Here's her before, here's her after. And I love this because, again, second case I showed in a row, on day 1, the records picture, she knew she was coming in to get her picture taken. Okay. But on the final day, she didn't know we were taking final pictures. And look at the dramatic change in that person that we elicited in her. Okay. This is a little exercise that I've developed to show you the effect of expansion on IPR. So here's a case here. We have lower anterior crowding, and the software says you need 0.5 IPR around the front in the anterior, distal of the canine to distal of the canine, 0.5 IPR, please. Okay. Well, I know that if we expand in the premolar area, just like if we're wearing a Schwartz plate, or if we were wearing a Hyrax or some sort of appliance, I know that expansion by opening up the circumference of that circle, we're opening up the diameter will increase the circumference by a factor of 3. So I know I want to see how much I can get away with if I expand. So I did this where I took the controls and I expanded these premolars. I expanded them right out. Now, this can never happen clinically, but I just wanted to see the effect. So look at, I brought these way past the ridge. I brought these ones way past the ridge. Look what I did to the IPR. I decreased the IPR from 5, 5, 5, 5, all the way across to 2, 5, and 2. A massive improvement on the IPR. That's the effect that expansion has on IPR. Okay. Then I went back to the beginning. I'm like, okay, let me see the effect that expansion of the molars have on IPR. Let me see what I can do here. But when I expanded the molars to obnoxious limits, I did not elicit quite as much change as I did when I expanded the premolars. Okay. What is the reason for that? Well, that only works in a straight wire system, or it only works when teeth are connected together. That doesn't, expansion of molars doesn't really work in plastic. I mean, it works for a couple millimeters, but that couple millimeters is not going to get you anywhere near the room that you need in the circumference of the arc in order to fit a tooth in or to solve your crowding problem. Okay. Expansion of the premolars only for a plastic system. Okay. Solving crowding. So extraction, we don't want to extract unless we have to, unless the tooth just doesn't belong there. Expansion is a yes. Distalization is a no-go in Brock territory. And IPR is safe and it's effective and it's good. Distalization, by the way, causes a realm of TMJ problems, so we stay away from it like the plague. And we don't talk about distalization in Brock's course, okay? But we do talk a lot about IPR, okay? Adult clear aligner therapy is heavily dependent on IPR. Not true of straight wire systems because the wires basically drag the teeth where they need to be, okay? And clear aligners lack anchorage to bodily move molars. So we depend on IPR, okay? Sometimes expansion alone cannot solve all the crowding. So IPR is a predictable way of making space. Problem is, there are several different ways to IPR. If you use a disc, you're in danger of doing this, okay? If you use a disc, you're in danger of doing this. If you use a disc, you're in danger of doing this, okay? If you use a disc, you're in danger of doing this. Now, let me just tell you something about this case. This gentleman here was my iTero rep, but before he was my iTero rep working for a line, he worked for a company called, I don't know, Dentsply or something, Dentsply Sirona. He worked for another dental manufacturing company that had their own aligner system. And their technicians and their doctor prescribed 0.5 IPR right between the central incisors. Okay. The problem with this here is that they could have done 0.2, 0.2, 0.2, 0.2, 0.2, and achieved a far better result than just 0.5 and see how it goes. Because now he came to me for treatment and it was up to me to fix this. And this is a hard fix. Okay. This is where I got him, but I still think I'm going to have to end up bonding in between. I might use some BioClear curved strips or something. Okay. When I see this now, I cringe because look at all the danger that's going on here. Look at the papilla is in danger here. The incisal edge is in danger here. If this air rotor doesn't have consistent torque, what if it grabs and kicks? And what if it cuts the lip? Okay. Here's what else makes me cringe. This came to me from Dr. Louis Corey here in Detroit, the inventor of quick strips, sends me all of his cases that he sees that people send him by virtue of being the inventor of quick strips. This is disc IPR. Okay. This is anatomically not correct. Okay. But the problem is the patient's been in treatment for 4 years and the doctor keeps going to refinement. The doctor cannot understand why the spaces won't close. Well, it's because this here. The teeth touch interproximally down below, but they've just created a huge wedge occlusally here and here. Okay. Here. Okay. That's inadequate and improper technique or armamentarium, I should say. What does IPR mean to you? To me, it means quick strips only, all the time. There are some other things. Dr. Galler is the founder of the Ghost technique, and that's pretty good. It's a disc like with a racing stripe, but the cutting edge is supposedly safe. I like to do it by hand. I like to do it old fashioned with the quick strips. The clinic pack looks like this. The refill packs look like that. And here's the reason why I do what I do, because if you look close at these lower incisors, you'll see that the curvature of the tooth remains the same. See, these aren't toothpicks. These aren't fence posts. I have not right angled the incisal edge. I didn't do any of the bad things associated with IPR on the lower anterior teeth. That's why I will never sway from using a quick strip. Okay. I have an office full of them. Okay. Here is, I don't know if anyone recognizes Queen of Invisalign, Christina Blocker, who was lecturing at my study club. This is Dr. Louis Corey, inventor of quick strips. This is the factory. These are the injection molding machines. And we went and we made our own quick strips one night, taught us how to do it. We made our own. Okay. This is what we looted when we were there. We got all these quick strips. Okay. This is what we walked out with. And for that reason and for other reasons, I like to promote Louis and the quick strips, but safety first and proper IPR second. Okay. Speaking of delivery of care, I want to just jump on Munchies for one quick second. Munchies is an acceleration device. Munchies is the common denominator among all aligner therapy. I don't care if you use Invisalign. I don't care if you use the product from Reveal, SLX, Uline, Candid, whatever it's called. Your treatments will go smoother with Munchies. Okay, Munchies is an acceleration device. It helps seat the trays, but it also helps flex the trays so that it fits over the attachments better and you get better efficacy and releases cytokines. Cytokines being a chemical that you need to get teeth to move, to break down bone. It's a pro-inflammatory protein. Okay, this is just a quick little demonstration here. Looks like it's unavailable, but it looks like this. So these ridges here help seat in the premolar area. This slot right here is good for the upper anterior incisal edge. And this slot over here is good for the lower incisal edge. So you line it up and you just start munching down, okay? I instruct my patients to do 7 to 9 minutes 4 times a day, okay? 3 T movements. Tip is good. Translation, good in the anterior, kind of baddish in the posterior. Torque, not if we can help it. Not if we can help it. We don't want to do that. Putting all these movements together, I want to show you this case here. Here is a wonderful case where patient's pre-treatment occlusion, you can see the green marks on the incisor. She had an end-to-end bite. She had elements of an open bite. She had a little bit of crowding going on. So we had some things to fix. Okay. So my considerations for this case was, how do I solve the crowd? What are my tools to solve crowding? What are my tools to solve the end-to-end bite? What are my tools to solve the open bite? So we're going to solve the crowd. We can use proclination and we can use IPR. We can also use distalization and we can use extraction, but those 2 are off the table. So it's always expand and procline or IPR. Okay. Which one do we use? How do we solve an end-to-end bite? Well, you can procline the upper and you can IPR the lower. Okay. And how do we solve an open bite? We can procline the upper and then then IPR the lower and then drive everything down with extrusion attachments to close down the bite. Okay. Here's my attachments and my IPR plan. Horizontal bevel for anchorage, horizontal bevel for anchorage, horizontal bevel for anchorage, horizontal bevel for anchorage. Let's move to the other side. Same thing. 1, 2, 3, 4 horizontal bevels for anchorage. That rarely changes unless I'm solving a deep bite. Okay. Across the front, extrusion, 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 extrusion. Across the bottom, extrusion, 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 extrusion. Canines have raindrops because they're going to rotate just a tiny bit, and minimal IPR across the front to solve this. Okay. Here's my treatment plan. Here's how it's going to go. Okay. And this went absolutely according to plan. I had a 1000% compliant patient. Okay. This open bite was solved. The crowding was solved. The interdigitation is fabulous. Okay. This was by far a successful case, except for the pictures. Could have been better. Okay. Happy and happier, as I always say. Okay. The things that I can and cannot live, the things that I can live without, and the things that I cannot live without. Unwanted movements, inefficient movements, AKA movements that don't go to completion easily, that will cause you to go into a refinement. Those things I should eliminate from my plan. Okay. This is clear aligner dogma. This is what clear aligner dogma states. It states that if you have a case that only has tipping and anterior translation, you'll probably be done on the first round. If you can design a case where you can solve everything by tipping and anterior translation, congratulations. You've collected all the money for the case. You've paid your lab bill. You probably won't have to see that patient again. Okay. But the more rotations you put into your plan, the more root torque you put into the plan, the further from the finish line you are. Then it becomes a question of compliance. Then it becomes a question of acceleration devices. Okay. So you open yourself up for variability in treatment when you add root torque and rotations. Okay. High volume providers, they have to minimize refinements. And I'll tell you why they have to minimize refinements. Because if you do 100 cases in 6 months and you have half of them go to refinement, the next 6 months, you have 150 cases, you have 150 patients. Okay. And if your 150 patients, if half of those go to refinement, now you have 225 patients. So you can never have enough room. You can never have enough team members. You can never have enough physical plant location to accommodate all the people that are going to be coming in for refinements. Not to mention the dump truck full of money that you're going to need to pay everybody to do free work for you, because that's essentially what it is. So we want to minimize refinements, not only for the patients asking you if you know what you're doing or not. We want to minimize refinements from a financial aspect as well, from a workflow aspect, from a job satisfaction aspect. My last 6 months, I had exactly the same amount of cases that I started as I had retainers that I started. So somewhere I think that's good. I think that I should try to continue the same amount of cases as the same amount of retainers. I think eventually that'll work itself out, and it will be the same amount of people entering treatment as exiting treatment. I think that would be good for my office. Okay. One thing we want to avoid, mesial distal crown angulation. Let me explain this here. These lateral incisors have programmed into the treatment mesial distal crown angulation. You know what that is? That is when I think about it like this. If I'm attaching a steering wheel to a tooth and I need to turn that steering wheel to get that tooth into position, that movement doesn't happen. That movement is extremely difficult, okay? There's not a great attachment that can make that happen. And there's not great surface area on the teeth where you can grab an interproximal edge and get the change you want. You have to elicit that change by grabbing something on the facial and twisting and torquing that. It's a root torque movement. And you only got plastic on the front and on the back of that too. So that movement doesn't happen. So whenever you see mesial distal crown angulation, try to remove or try to minimize. I'm going to show you how to do it right now. I'm opening up my modification. Okay. Right there. Here comes my tooth chart. I'm going to turn off IPR and turn off attachments so you don't get confused. I'm going to highlight the lateral incisor and I'm going to count up 1, 2, 3, 4. Fourth slot in, that is my steering wheel movement. I'm going to take it down from 10 to as much as I can take it. And as I'm taking it down, I'm going to look at the tooth highlighted in white to make sure if it still looks good. Keep in mind, I manicure every incisal edge at the end of treatment. So if you think it doesn't look great, I'm going to level it. I'm leveling everything and I'm enamel plasting everything, every time, every treatment, every patient. So I know that I can make it look good. So I'm going to remove this mesial and distal crown angulation each and every time to make my life easier. Okay. The next thing I want to eliminate, canine and premolar rotations. It's not exactly a root torque. You're not exactly swaying that root through bone. It doesn't look like a windshield washer movement. But what it is, some of these teeth, some of these canines and premolars can have very, very broad roots. And when you need to twist a broad root, like say on a canine, you need to twist it through bone. That requires a lot of energy from the plastic. It requires a lot of compliance. It requires a lot of anchorage. Usually rotation movements, you'll see those show up again in refinements because they hardly ever go to completion. Let's take a look at how we reduce that. So I'm going to take a look at my upper right canine number 6, number 1, 3. Okay, I'm going to highlight it and I'm going to go to the rotation. I've got 19.6 degrees of mesial rotation. So I'm going to bump it down, bump it down, bump it down, bump it down until I think it's useful. If I can get it under 15, I'd be okay. If I can get under 10, that'd be great. Okay. If I can get it under 5, I wouldn't need that big fat attachment. People hate that attachment. So I always do everything. Sometimes you can't get rid of it all the way, but the more I can get rid of it, the better off my treatment is and the closer to the finish line I am. So high volume providers that have little tiny refinement rates. Okay. These are the tips. These are the secrets. Remove root torque and remove rotations as much as you can. Okay. Third movement, I cannot live without GAPE, Galler Anterior Intrusion Protocol. When you need to solve a deep bite, you need to adhere to this method. Ask for it by name, and Invisalign knows what it is, or you can program it yourself with 3D controls. It exists like this. Lower premolar. Here's a deep bite that I solved with it. That's pretty dramatic, one of my first ones back in 2019. Here's what it looks like. Horizontal bevel for anchorage, and then boom, optimized deep bite attachment right here. Okay, nothing special in the anterior, but here's how you recognize it. Second premolar gets a horizontal bevel. First premolar gets an optimized deep bite attachment. And then the kicker, lingual attachments on the canines. Lingual attachments on the canines. So this adds an element of anchorage very, very close to the action site, very close to where the action is taking place, okay? Invisalign, this is their protocol. 2 optimized deep bite attachments on the premolars, okay? But in the anterior intrusion protocol by Galler, he exchanges one of these for anchorage here. It's more important to have anchorage. And he doubles down by putting more anchorage on the lingual of the canine. Does everybody understand that? So we're adding more anchorage to elicit to affect the change that we need. Okay, that's very important. Every time you have a deep bite in your Clinchecks, just write back and say, make sure this is Galler anterior intrusion protocol, because it works flawlessly, at least up to 1.5, sometimes 2 millimeters with compliance. Okay. One of the last things we need to talk about is overjet. Okay. In treatment, we want decoupled anterior teeth. And decoupled means all these things: sever, remove, disassociated, detached, disaffiliated. Okay. So I went and looked for the thickness of different aligners. Okay. And Invisalign aligners are roughly 0.7 millimeters. Okay. So if we add up aligner thickness, okay, 0.7 millimeters on the top, 0.7 millimeters on the bottom, roughly 1.5 millimeters. Okay. So we want 1.5 millimeters of overjet. Why? Because when we take off the trays, we're going to close the vertical by that much. And if we don't have 1.5 millimeters of overjet, our teeth will be clanging together prematurely, leading to a posterior open bite. We spend about 3 hours talking about posterior open bites in Brock's course. Okay. So this case here from the front, I'd say the overjet looks pretty good. But when I look up underneath, this is tight. This is a tight overjet. That might be adequate in the straight wire case if they've solved the curve of SPE. But in an aligner case, you just want to make sure that you've got adequate overjet. And here it is, in table form, diagrammatically. Okay. Overjet table, we need more. Okay. We need 1.5. So we need to program more IPR. That's one of the tools we have for overjet, or IPR. Last thing I want to talk about, the attachments, the magic of the horizontal bevel. We already discussed that length. One of the most important attachments that you will come across, the horizontal bevel. Trays click in, it's preferred for anchorage. Trays snap in and engage. Patients hear that click, they know the tray is seated. Okay. One of the problems with retainers is that we take the attachments off, patients don't know if it's seated or not. Okay. An audible click is just a feedback so that the patients know that their trays are seated. Okay. Everybody take a look at these 2 upper premolars here. They are rotated. Okay. But the horizontal bevel is still the king for premolar expansion. You can swing out and you can do rotations, and it still functions as anchorage. That's why it's a utility attachment. Okay. Check out the attachments that I've chosen. Note the attachments. Okay. And this is what this treatment looks like. This is my time lapse. You can see the extreme amount of rotation that I got by using horizontal beveled attachments. Okay. Lower, same thing. 2 flared out lower premolars. Okay. They got horizontal bevels. Okay. Why? Because it provides a good grip. There is no plastic that could get rounding the canine, get in between this premolar, in between this premolar, in between this premolar, and cause it to turn. No plastic can do that. You need to grip something sturdy, like a big horizontal bevel. Okay. And add anchorage to this case kindly. Thank you. Okay. Old Faithful, don't be quick to jump on an optimized attachment, and it's what propels efficient treatments. Okay. My last case before we're done, class 2 mandibular maxillary crowding. Okay. IPR is a necessity in class 2 cases. Okay. Because if we procline and expand and flare out, you would have way too much overjet. Okay. So we have a moderate amount of IPR to do here. Okay. Here's the plan. Here's how everything is going to go according to this plan. It's going to procline out, and IPR is going to bring it back in. We're going to get adequate overjet. Okay. Simple and straightforward. Here's where we are at this time at refinements. Okay. Checking the attachment. I have adequate anchorage. I still have a little bit of a deep bite to solve. So we have a deep bite attachment here. Here's my anterior intrusion protocol that we discussed. Okay. Went from here to here, from there to there, here to here. Here's the most important part of this case. I show this every time because I'm addicted to this case, because this is what he looks like before, and here's what he looks like after. This is a completely different person. He went from like a cross between a frat boy and a pirate to something warm and approachable and very almost, way more human-like. Okay. That's why I do what we do. These patients are in your office. I always tell everybody, these patients are in your office. I don't have a different subset of patients. I don't have patients that are any more or any less compliant than you. I don't go out and search these patients by a special method. They all walk through the door. I just know how to apply the Clincheck for success. And I urge everyone, be an agent of change. And thank you. Here are our upcoming 4-day courses in Toronto, Dallas, and Chicago. Please get a hold of Lee, and she will set you up.
Ron, that was a great job.
Thank you.
I made a few notes. The first thing I want to say is it's a good thing your course is 4 days,
Yeah.
because boy, you were throwing it out pretty fast there. And I also like the fact that you told me, and I've been told that about your course, that you repeat the attachments 4 times in your course. Plus, we have a course manual that lists them all in detail about the attachments, because that really is a key to understanding how to do your case.
Yeah.
The other thing, we have 180 people signed up for this course tonight. Not all of them went on tonight, but they're all going to get a copy of your video that they can review. So let's see what else. I tell you what impressed me. One of the things that impressed me the most is you take 17 weeks to do your course. I take 17 months to treat my patients. So
Yeah.
So obviously you're a lot more wealthy than I am. So anyway, you're all, well, I mean, it's great. You're doing a great job. And I think one of the main things you always say in the course is stay in your lane.
Yeah.
Pick cases that are easy. Don't get in over your head, and refer the tough ones to somebody else, and just do the easy cases and have some fun. And I agree with you. One of the reasons I like it so much too is that the before and after pictures are phenomenal, and they just make you want to go to the office every day.
Yeah.
And plus the neat thing is that Invisalign's done all your marketing for you.
Right.
I mean, they all know about Invisalign. There's no marketing involved. So all
Right.
you have to do is tell the patient you offer Invisalign and start talking to them. And again, you have to train your whole staff. And I think you recommended the staff come to the course so they can learn how to answer questions of the patients and whatnot. We did have some questions here. A couple of them you've answered during the presentation, but one of them is, I've always heard there are problems in Invisalign because the cases end in a posterior open bite. Why is that? Now, you mentioned that you have a 3-hour lecture on that, so maybe we better not get into 3 hours of that. But
well,
I mean, that's
four causes, 4 solutions, 4 preventions, and the most important one is anterior interference, and that comes from not enough overjet.
Okay, well, we'll wait for your 3 hours on that one.
Okay.
The other one's, why are refinements considered bad? Now, you talked about that quite a bit at the end.
Yeah.
I always thought they're part of the process. My patients like when I fine tune their treatment. I guess refinements are bad from a dentist standpoint because it's time consuming, and the more they sit in your chair, the less money you make, but you certainly want to get it right. I think the biggest problem with my students is that they get 90% in the first maybe 9 months. And then they spend the next 9 months trying to get the last 10%. And sometimes we're just a little too critical of our work, and the patient would rather have a 90% and leave 9 months earlier. And I think that's what we all have to think about. And if you ask the patient what they want straight front teeth.
Right.
And they want a good bite, and of course, good health and all the things you recommend. Another guy said, is there some place I can get a summary or a list of the things you describe and look at the Clincheck? Well, I guess, that's a hard thing to do. I mean, the manual is got several pages, probably, I don't know, maybe 20 pages on Clincheck.
Yeah.
And the attachment. So I mean, tonight was a great intro for people to see how they like your lecture style, how they like your hairdo, the fact that you applied gray to your beard to make you look older. Bill Van Evans and I are gray all over, and but you're looking much more mature with that gray beard, and I think you did a great job. And the other interesting thing is that everybody that went on stayed on. And you were over you're over the hour. It's hard to concentrate on anybody for an hour, but you did a good job. So thank you very much. And thanks everybody for attending. Now, remember, you get a test.
Yeah.
And if you pass the test, you get the CE credit. So Lee will send you the test and send it in, and we'll give you the CE credits, and you can use for your, for CE. And that's great, Ron. Thanks again. You did a great job. And every time I hear you, you're a better speaker. And
Awesome.
Keep it up. Someday you can take over the whole course.
Yeah.
Okay, Bill, thank you for attending. And remember, everybody, Bill may send you information on his lab if you want to get into those appliances that, as Ron mentioned, if you want to expand the case, you're better to use a functional appliance and depend on the Invisalign trays. And an awful lot of people need arch development. And the thing I like is if I do arch development with those appliances, I don't have to slenderize so much. And also they end up with a slightly better smile and a better airway, and they can breathe better. So anyway, the combination of what you do and what Bill does is a winner. So anyway, it was a pleasure listening to you again.
Thank you.
I still don't understand everything you say. I mean, there's a lot to it. There's a lot to it. I mean, boy, if your course is 4 days and you spoke for an hour, you know a lot. So again, keep up the good work, and I'll look forward to seeing you in Toronto in September.
Yes. Yep, I'll be there.
Okay.
Thanks, Brock.
All the best, everybody. Thanks for coming in. And if we can help you in any way, you want information more on his courses, you want to call Lee, and we'll be happy to get you involved in his courses and help your practice grow.
Perfect.
Okay. Thanks again, Bill. Thanks, Ron. Thank you, everybody, for attending.
Good night.
And your mother, too.
She's there.
I see her waving at me. That's good. I mean, you talk about a mother that'll listen to you for an hour and a half like that is fantastic.
Yeah.
Okay.
Thank you.
Good night, everybody.
Bye.
Good night, everyone. Thanks.
Bye.